Welcome, Zoo Assembliers! My name is Zouk Azalishvili and I'm the founder of Zoo Assembly. Zoo Assembly is an online podcast for the highest yield basic science and clinical knowledge tested on USMLE Step 1 and USMLE Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zoo Assembly. Now, let's start rolling. Today we are continuing our pediatric series, and this will be the episode 3 of our pediatrics series. We will talk about several different conditions, just as we do for every episode of USMLE Step 2 CK, and we will discuss them in detail, and we'll emphasize the highest yield points that you'll need for the USMLE Step 2 CK exam. Let's start with the developmental milestones during the first year of life. And before we start discussing these milestones, let me tell you one thing. In general, it's very challenging to remember all of the different ages and the different types of milestones at those ages unless you are already a practicing pediatrician. Because when you are a pediatrician, then you see the children with normal and abnormal developmental patterns all the time, and therefore it becomes almost automatic for you to detect whether something is abnormal or normal. In contrast, it's a little bit more difficult for the students, and I think the board exam and the people who create the board questions understand that it's very difficult to remember the exact ages. But as long as we know the approximate ages for the different milestones, then I think that we are good to go and we'll be able to answer most of the questions about these developmental milestones. Let's start from the 2 months of age. And when we talk about the different ages, we will discuss the gross motor milestones, fine motor development, language, and finally social cognitive development. At the age of 2 months, the infant should be able to lift the head while lying in the prone position. It means that the tone of the infant body is strong enough for the baby to hold his or her head in the prone position. As for the fine motor development, the hands are unfisted for the 50% of the time, and 2 months old infant should be able to track the things past the midline with her or his eyes. As for the language, 2 months old baby already alerts to the voice and to the sound, especially that of familiar people like parents or the guardians, and 2 months old infant also coos. As for the social and cognitive development, 2 months is the age when the infant develops the social smile and also recognizes the parents. Now, when we talk about the 4 months of age, then this is the time when the infant can sit with the trunk only with support. And at the same time, 4 months of age is the age at which the infant starts rolling from side to side. As for the fine motor development, the hands are now mostly open. If you remember, when we were talking about the development at the age of 2 months, we were saying that the baby's hands are unfisted for 50% of the time, roughly. In contrast, now that we are talking about the 4 months old infant, we are saying that the hands are mostly open. And at the same time, infant can reach the midline by her or his hands at the age of 4 months. As for the language development, the 4 months old infant can already laugh, and it can turn to the voice, meaning turn his or her head to the voice, and when we talk about the social cognitive development, this is when the 4 months old infant enjoys looking around and just looking at the different things and also people. Let's continue. Now we'll talk about what happens to the infant who is 6 months old. A 6 months old infant should be able to sit propped on hands, unsupported. Actually, unsupported sitting should be achieved at 6 or 7 months of age. As for the fine motor development of a 6 months old baby, the infant at this time should be able to transfer the objects from hand to hand, and at the same time, she or he should have the raking grasp. So assemblers, do you know what the raking grasp is? I hope you do, and if you don't, that's not a problem because we will explain it right now. The raking grasp is when the infant just grasps the object with all the fingers except for the thumb. It's a very weak grasp, which is then followed by the palmar grasp, when the baby can actually put the things in his or her palm. And then we have the pincer grasp, when the baby, the infant, can hold the objects between the thumb and the index finger. And we'll talk about this when we move on to the later stages of development. But let's get back to the 6 months old baby. And now we will discuss the language development at this age. This is when the infant already responds to his or her name, and the infant also starts to babble. As for the social cognitive development of a 6 months old infant, we have a phenomenon called stranger anxiety. Stranger anxiety is when the baby starts crying or feels uncomfortable when a complete stranger approaches him or her. And at that time, baby tries to be near the guardian, near the parent or somebody else who he or she knows well. At 9 months of age, the baby should be able to stand and should start to at least crawl. At the same time, 9 months of age is the age at which the baby develops the 3-finger pincer grasp. Here's the thing. Pincer grasp can be either 3-finger pincer grasp or 2-finger pincer grasp. 3-finger pincer grasp is when the baby can hold the objects between her or his middle finger, index finger, and the thumb. And this is what happens at the age of 9 months. At the same time, infant at this age should be able to hold the bottle or the cup. Speaking of the language development at the age of 9 months, the baby should be able to say dada and mama. And finally, 9-month-old baby is usually able to wave bye and also can play pat a cake. Let's move on to 12 months of age and talk about what happens to the different aspects of the infant development at this age. Speaking of the gross motor development, the infant should be able to stand well at the age of 12 months. At the same time, 12 months is usually the age when the infant takes his or her first steps independently, and she or he can also throw the ball. 12 months is the age at which the infant develops two-finger pincer grasp that we already discussed. But let me still remind you guys, this is when the infant can hold the object between her or his thumb and the index finger. As for the language development, 12 months of age is the age at which the infant says the words other than mama and dada. And finally, this is when the infant develops separation anxiety. In general, the different resources mention the different age for the onset of separation anxiety. Some resources say that it's 9 months, but the others say that it's 12 months. However, once again, just as we said in the beginning of this discussion, the board examiners will not give you the age, which is controversial. So the questions will be very clear if they want you to assess the development of the child. As for the meaning of the separation anxiety, this is when the baby starts crying or feels uncomfortable and agitated if the parent or the guardian moves away, for example, leaves the room, and so on. Finally, 12 months old infant should be able to come to the person, mostly the parents, when she or he is called. And this is how we wrap up the discussion about the developmental milestones in the first year of life. Let's continue our discussion by talking about the differential diagnosis of the regurgitation and vomiting in infants. And in this subsection of our today's episode, we will be talking about 3 different conditions. This is gastroesophageal reflux, milk protein allergy, and hypertrophic pyloric stenosis, or shortly pyloric stenosis. Let's start with gastroesophageal reflux. Gastroesophageal reflux in the infants can be either physiologic or pathologic, and only when it's pathologic, this is when we call the gastroesophageal reflux the GERD, that is gastroesophageal reflux disease. Let's now define what differentiates the physiologic gastroesophageal reflux from the pathologic reflux. When the baby has physiologic reflux, the baby is totally asymptomatic, and sometimes she or he is called happy spitter. They are called happy spitter because they might get some food out of their mouth after breastfeeding, but they are calm, they are active, they are playful, so they are not distressed. And in that case, the management of physiologic reflux is just reassurance of the parent. We should educate the parent about the fact that mild regurgitation of the breast milk or formula without any distressing symptoms in the infant is normal, and what we can do to minimize the reflux is to establish the positioning therapy. In other words, once the baby stops feeding, then we should try to maintain the baby in the vertical position for approximately 30 minutes so that the breast milk or the formula does not regurgitate up through the esophagus. In contrast, when the baby has pathologic reflux or GERD, this is when the symptoms come into play. If the GERD is pathological, the infant is distressed and he or she has the failure to thrive. The parents might also complain of significant irritability of the infant, and very importantly, pathologic reflux in the infants is characterized by Sandifer Syndrome. Zeus Emiliers, do you know what the Sandifer Syndrome is? Are you telling me that Sandifer Syndrome is the arching of the baby's back after feeding? If you are, that's totally correct. The Sandifer Syndrome, or the back arching after infants feeding, is sort of protective mechanism by which the infant tries to prevent the regurgitation of the food. And if we diagnose the infant with the pathological reflux, then we need the multifaceted management. First of all, we should start administering the thickened food to the baby, because when the food is thickened, then it's less likely that this food will be regurgitated after the feeding is over. Additionally, the infant with GERD might need the antacid therapy, because we mentioned while talking about the symptoms that the infants with pathologic reflux have significant irritability, which can potentially be explained by the acid reflux in the esophagus, which burns their esophagus and it might hurt for them, but they certainly cannot tell us that it hurts in their chest. So antacid therapy will minimize the acid reflux into the esophagus, and therefore it will symptomatically alleviate the infant's condition. Finally, if pathological reflux is really severe, then we should diagnose the reflux definitively by esophageal pH probe and also upper endoscopy to see what happens to the esophagus. Are there any esophageal erosions or the ulcers? What is the tone of the lower esophageal sphincter? And so on and so forth. This was discussion about the gastroesophageal reflux in the infants, but we will get back to this topic in today's episode, and we will talk about the mechanism and the pathophysiology behind the reflux in general in infancy. But for now, let's move on to milk protein allergy. As the name implies, milk protein allergy is allergy to the milk protein. We know that the most common allergenic protein in the milk is casein. And the symptoms of milk protein allergy might be regurgitation and vomiting of the milk. It might also be complicated by the eczema, that is atopic dermatitis, because we know that atopic dermatitis is an allergic reaction, specifically type 1 hypersensitivity. And in this case, the exposure of the infant to casein can stimulate the type 1 hypersensitivity in the form of eczema. And finally, we might also observe the bloody stools in the infant with milk protein allergy. In that case, milk protein allergy is also sometimes called allergic proctocolitis, which literally means allergy-induced inflammation of the rectum and the colon. Okay, how do we manage the infant with milk protein allergy? Well, we need to avoid the milk protein. So in that case, we need to avoid the casein. For example, we can give the infant casein hydrolysate if the infant is on the formula feeding, or if the infant is on breastfeeding, then we should advise the mothers to avoid the soy protein. The reason here is that the infant who has allergy to the milk protein is very likely to have the allergy to soy protein as well. And if the infant is breastfeeding, then maternal ingestion of soy can also be transmitted to the infant via breast milk, and we don't want to do that. So this is why we advise the mothers to avoid the soy in their diet. The final condition that we'll discuss in this subsection, is the pyloric stenosis. And as we know, pyloric stenosis is hypertrophy of the pyloric sphincter and the smooth muscle around the sphincter, which then causes gastric outlet obstruction in the infants. It is more common in the firstborn males, and it is especially common in case of in utero or postnatal exposure to macrolides, specifically erythromycin. Let's imagine that we have an infant who got the pertussis or who has chlamydia pneumonia, and we need to give them oral erythromycin. In that case, the infant might then present with pyloric stenosis. One very important point to remember about pyloric stenosis is that it does not present immediately at birth. The reason for this is that hypertrophy and hyperplasia of the smooth muscle around the pyloric sphincter takes time. It is usually not congenital, in contrast to, for example, duodenal atresia, which is either present or absent at birth. We already mentioned that pyloric stenosis causes gastric outlet obstruction, and it means that the food that the baby eats accumulates in the stomach and it distends the stomach, which causes the hyperplasia and hypertrophy of the gastric muscles, and since the gastric smooth muscle is so thick in this condition, this is why we can see the visible peristaltic or gastric contraction waves while inspecting the infant's abdomen. At the same time, physical exam might reveal the olive-shaped abdominal mass either in the epigastrium or the right upper quadrant, and this olive-shaped abdominal mass is the hypertrophic pylorus, which we can actually palpate. The patients with pyloric stenosis have projectile vomiting, and they have this projectile high force vomiting because when the food accumulates in the stomach and we have the thickened gastric muscle, then the strong contractions of the hypertrophic gastric muscles cause the ejection of the food through the esophagus. This is why they have projectile vomiting. One more important thing, and let me ask this as a question. Guys, what do you think? Will the pyloric stenosis cause non-bilious vomiting or bilious vomiting, and why? Are you saying that pyloric stenosis causes non-bilious vomiting? If you do, you are totally right. And the reason for this is that bile normally drains in the second or descending part of the duodenum. But pylorus is proximal to duodenum, right? Meaning if pylorus is hypertrophied and obstructed, then the mass and the content that is vomited up is from the stomach, and the bile cannot reach the stomach in that case because the gateway between the stomach and the duodenal bulb, that is the pylorus, is obstructed. So another high-yield point here is to know the metabolic disturbances of the infant with pyloric stenosis. Guys, what acid-base disturbance do you think this infant will have? I hope you're telling me that the infant with pyloric stenosis will have hypokalemic, hypochloremic, metabolic alkalosis. There are several reasons for this. Let's first explain the electrolyte disturbances here. Hypochloremia is caused by the fact that the baby is vomiting up the gastric content, including the gastric acid. And if we remember from our general chemistry, gastric acid is hydrochloric acid. They are literally losing chloride from their body, and this is why they might have hypochloremia. As for the hypokalemia, well, here we have a little bit complex mechanism. Yes, there is potassium in the gastric fluid. However, it's not that abundant to cause hypokalemia on its own. The reason for this is that, as we know, the parietal cells of the stomach contain proton potassium ATPase, which pump the proton outside of the parietal cells and pump the potassium inside the parietal cells. I mentioned this concept to help us realize that there is not enough potassium in the gastric fluid that the loss of gastric fluid can cause hypokalemia alone. The other mechanism, which is more important in this regard, is that babies with pyloric stenosis are commonly severely dehydrated from their vomiting. And here's my question, guys. Which endocrine system and the axis gets activated when we are volume depleted? Do you remember it? I hope you do, and I hope you're telling me that this is renin, angiotensin, aldosterone system. And when the renin, angiotensin, aldosterone system gets activated, we know that aldosterone can increase the sodium absorption at the level of the principal cells of the collecting duct, and it can secrete potassium in exchange for sodium. This is how babies with pyloric stenosis can develop hypokalemia. And we also mentioned that they have metabolic alkalosis. The reason for this is that activation of renin, angiotensin, aldosterone system causes contraction alkalosis. Let me remind you this mechanism from our step 1 knowledge. Excessive angiotensin 2 stimulates the sodium proton exchanger in the proximal convoluted tubule. And activation of this exchanger helps the reabsorption of the filtered bicarbonate. In other words, when there is activation of the renin, angiotensin, aldosterone system, there is reabsorption of the filtered bicarbonate, but at the same time, there is production of new bicarbonate in the alpha intercalated cells of the distal nephron. And this is the effect induced by aldosterone. And this is how the babies with pyloric stenosis can develop the metabolic alkalosis. The way we diagnose them is via abdominal ultrasound, where we can see the thickened and elongated pylorus, and the treatment is really straightforward. In that case, the problem is thickened pyloric sphincter. Therefore, we need to cut that sphincter. We need to make it thinner so that the contents can go from the stomach to the duodenum and further down the GI tract. And the procedure by which we incise the pyloric sphincter and make it thinner is called pyloromyotomy. One more high-yield thing about pyloric stenosis, and let's move to another topic. Before we perform pyloromyotomy, we first need to correct the electrolyte and acid-base disturbances of the infant to increase the success rate of the surgery. This is extremely high yield. In other words, we need to try our best to correct this hypokalemic, hypochloremic metabolic alkalosis via fluid resuscitation before we move on to pyloromyotomy. And this was discussion about the differential diagnosis of regurgitation and vomiting in infants. As I promised you, we will discuss now the mechanism of the gastroesophageal reflux in infants. And what we're going to discuss right now is completely normal. This is the mechanism for physiologic gastroesophageal reflux, but when this reflux becomes excessive and it becomes symptomatic with infantile distress and failure to thrive, this is when we call it GERD, or pathological reflux. Okay, let's talk about the reasons for which the infants are at risk for regurgitation of food. First of all, infants have shorter esophagus compared to adolescents or adults. And when there is a shorter esophagus, then the gastric content have a short way up until the oropharynx, so they can regurgitate quite easily. At the same time, infants have insufficient tone of the lower esophageal sphincter. To put it more correctly, in infants, the lower esophageal sphincter does not close completely and normally, and this is why gastric contents and the gastric juice can regurgitate back into the esophagus. And once again, these are the reasons why the infant can have gastroesophageal reflux, especially in supine position. And I think we understand why supine positioning is the risk factor, because supine positioning is the risk factor for exacerbation of the GERD symptoms even in adults or adolescents. Needless to say that it will cause GERD or physiologic reflux in the infants. When we lie down, then it's easier for the gastric contents to regurgitate all the way through the esophagus, because now they are no longer moving against the gravity. So gravity doesn't have the effect on the food boluses that are in the stomach. And as we already mentioned, upright positioning after feeding can significantly decrease the degree of reflux in infants. Okay, now let's move to another topic, which is diabetic ketoacidosis in children. The presentation of DKA in children is not that much different from that in adults. We know that DKA is more common in type 1 diabetes mellitus, right? Guys, can you please remember why DKA is more common in type 1 diabetes versus type 2? Are you telling me, okay, let's wait for several seconds and then you can tell me the answer. Are you telling me that in type 1 diabetes we have absolute insulin deficiency and this causes the lipolysis with subsequent ketogenesis in the liver? If you are, you're totally right. To put it in other words, the problem in diabetic ketoacidosis is hyperglycemia as well as ketoacidemia and ketoaciduria, because those fatty acids which are mobilized from the adipose tissue into the liver are converted into the beta hydroxybutyrate and acetoacetate. Once they come out of the liver into the blood, then acetoacetate can be broken down into the acetone, which is exhaled through the lungs, and this is what gives the breath of DKA patient this fruity odor which smells almost like a nail polish, which is quite specific for DKA compared to HHS, or hypersmolar hyperglycemic state. Let's get back to DKA. Patients with DKA have polyuria and polydipsia, which can also be present in type 1 and type 2 diabetes without DKA and HHS, and this is caused by osmotic diuresis due to glucose. But DKA patients, including children, also have vomiting and the abdominal pain. The exact mechanism of the severe abdominal pain in DKA is not known, but it's proposed that the keto acids cause, and the severe high anion gap metabolic acidosis causes irritation of the peritoneum, which causes this diffuse type abdominal pain. They might have the weight loss and they might have fatigue due to all of this acute loss of water. Another important finding of DKA is Kussmaul's respiration. Zooassemblers, do you guys remember what the Kussmaul's respirations are? I hope you're telling me that these are the deep, rapid breathing, and this is the compensation for the high anion gap metabolic acidosis seen in the DKA. And the reason why we have high anion gap metabolic acidosis is that, as we already mentioned in the beginning of this discussion, DKA is characterized by keto acids, specifically beta hydroxybutyrate, which is in fact more abundant than acetoacetate, and acetoacetate. We can detect the keto acids or ketone bodies either in the blood or in the urine. However, the urine dipstick usually detects the acetoacetate but not hydroxybutyrate. Regardless, we should know that beta hydroxybutyrate is more abundant in case of DKA due to excessive NADH in the liver. The laboratory findings for DKA include glucose more than 200 because, once again, DKA is caused by absolute insulin deficiency, especially during the time of physiologic stress. Guys, can you tell me the potential reasons for the physiologic stress of the body? Are you saying infection? Are you saying sepsis, myocardial infarction? All of these conditions, and this was definitely not the comprehensive list, are considered to cause the physiologic stress, and we know that during this stress, the body produces counter-regulatory hormones like glucagon, like epinephrine and cortisol, and the insulin levels go down. This is why the physiologic stressors can induce DKA in patients with underlying type 1 diabetes mellitus. Very importantly, DKA might even be the first presentation and the first manifestation of type 1 diabetes, and this is a very dangerous condition, very dangerous situation. Let's imagine that we have a child who is a 10-year-old boy, and suddenly he starts vomiting all over, he has very, very diffuse abdominal pain, he's confused, and when he is admitted to the hospital, we see that he has glucose of, let's say, 500 milligrams per deciliter, bicarbonate is less than 15, pH is less than 7.3, and ion gap is high, more than 14 in that case, and we can also detect the serum and urine ketones. By these laboratory findings, we can diagnose this patient with DKA, but the thing is that we did not think about the possibility of developing DKA in this child because we did not know about his diabetes in the very first place. Okay, now how do we treat the DKA in general, including in children? Since these patients are severely dehydrated, we need the fluid replacement. And at first we go with isotonic fluid, most likely normal saline, and we should give approximately 10 milliliters per kilogram of the isotonic fluid bolus over the 1 hour. At the same time, these patients need insulin infusion because, as we know, DKA is caused by absolute insulin deficiency, and at the same time, they need potassium repletion. Before we go into any further detail about potassium repletion, let me ask you a question, guys. Is the potassium level of a DKA patient high, normal, or low? In fact, it might be any of them, but most of the times, DKA patients have either normal or even high serum potassium concentration. But please don't fall for that, because the reason for why they have false hyperkalemia in brackets is that they don't have the insulin, and insulin shifts the potassium into the cells. So no insulin means that potassium stays out of the cells. However, these patients also have osmotic diuresis, and osmotic diuresis causes excessive potassium clearance, meaning the patients with DKA have depletion of total body potassium stores, but their serum potassium concentration might seem normal or even high. If serum potassium concentration is low, it means that the patient with DKA has severely depleted potassium stores, and we definitely need to replete the potassium. However, we need to be cautious here. We cannot replete potassium whenever we want. It really depends on the serum potassium concentration. If serum potassium is really high, more than approximately 5.3 milliequivalents per liter, then it's very dangerous to replete potassium because it can induce the arrhythmias, and finally it can cause sinusoidal rhythm or even cardiac arrest. Therefore, once the potassium goes down between 3.5 to 5 or 3.5 to 5.3, this is when we can start potassium repletion. Another important point that I would like to tell you guys is that when we give insulin, specifically regular insulin, to the patient with DKA, certainly their blood glucose will go down. If the blood glucose goes down to 200 to 250 milligrams per deciliter, this is when we can add the 5% dextrose to the intravenous fluids to avoid hypoglycemia. The reason for this is that hypoglycemia is just as dangerous, if not more dangerous, than hyperglycemia. The mortality rate is really high in both severely hypoglycemic and hypoglycemic patients. And finally, a very important complication of DKA is cerebral edema. And the mechanism for cerebral edema lies in the osmotic shifts. We know that glucose is osmotically active substance. It creates the osmotic pressure, across the two fluid compartments. In that case, let's say interstitial fluid and the plasma, right? And the intracellular fluid and the interstitial fluid. If we give insulin too rapidly, it will cause a very sudden, abrupt drop in the blood glucose levels. And when there is abrupt drop in the blood glucose levels, then the serum osmolarity will decrease relative to intracellular osmolarity. Here's my question to you guys. In which direction do you think the fluid will flow when the serum osmolarity decreases? Will it flow into the cells or will it flow out of the cells? I hope you're telling me that the fluid will flow into the cells, because osmosis means the movement of the water from low solid concentration to the high solid concentration, right? It's the opposite of the diffusion. This will cause swelling of the neurons, and swelling of the neurons can enlarge the total brain mass, which can then lead to brain herniation, and the brain herniation can be rapidly lethal if it causes compression of the brainstem with the compression of the respiratory and cardiovascular centers. So this was discussion about the DKA. It was not focused on the pediatrics specifically. However, we discussed several high yield points about this condition. Now let's talk about the different topic, which is totally unrelated to DKA, and this is diphtheria, tetanus, acellular pertussis vaccination, or Dtep vaccination. We will talk about the schedule and the contraindications of this vaccine here. First of all, let's again revise the components of the Dtep vaccine. Dtep vaccine contains the diphtheria toxoid, tetanus toxoid, and the pertussis antigen. Specifically, this is the conjugated pertussis antigen called pertactin. Therefore, it confers the immunity to diphtheria, tetanus, and pertussis. We have the Dtep formulation. We also have the Tdep formulation. And the difference between them is the relative concentration of the diphtheria toxoid. When we say that it's Dtep, then diphtheria toxoid is present in high concentration, and this formulation is usually used in kids. And when we say that we have Tdep, it means that the concentration of diphtheria toxoid is reduced compared to tetanus toxoid, and this formulation is mostly used in adults. Now we are talking about the Dtep. Usually 5 doses of Dtep are given to the children. The first 3 doses are given at the age of 2, 4, and 6 months. And if you remember, most of the vaccines in the vaccine schedule of the infants are administered at these 3 points in time. Well, definitely not all vaccines have 3 doses. Some might have less doses, some might have more doses, but 2, 4, and 6 months are the highlights of the vaccine schedule. The 4th dose of the Dtep vaccine is given between 15 to 18 months of age, and the 5th dose of this vaccine is given at the age of 4 to 6 years. After this, we should give tetanus toxoid every 10 years to boost the immunity. The reason being that the toxoid vaccine stimulates antibody production, and the antibodies have a certain half-life. They get depleted after a certain amount of time, and this is why toxoid vaccines, or the killed inactivated vaccines, usually need the booster. Okay, now a very important topic here. What are the contraindications to the Dtep vaccine? First of all, this is anaphylaxis to any vaccine component. And this is the contraindication for not only the Dtep vaccine, but for any vaccine. If a patient X develops the anaphylactic reaction to the first dose of the vaccine X, then we should not give another dose of the same vaccine to that same patient. This is a general rule of thumb for all the vaccines. But at the same time, another contraindication is encephalopathy after the previous dose of the Dtep vaccine. Encephalopathy might present as confusion, it might present as neurological symptoms, seizures, and so on. And this was a brief overview of the Diphtheria, Tetanus, Acellular, Pertussis vaccine with its schedule and contraindications. Let's move on to another topic, and now we will discuss the Edwards syndrome. Before we go to any further detail about Edwards syndrome, let me ask you a question, guys. Zoosomeliers, do you remember which trisomy is the Edwards syndrome? I hope you're telling me that it's trisomy 18. In contrast to Down syndrome, which is trisomy 21, and Patau syndrome, which is trisomy 13. Edwards syndrome is the second most common viable trisomy after Down syndrome, and the incidence for Edwards syndrome is approximately 1 in 8,000 live births. However, I'd like to tell you that the incidence and generally statistical data is always changing, and it's not worth remembering it unless you really want to remember the incidence of the Edwards syndrome, for example. It's more important to remember the clinical features of this syndrome so that we can recognize this condition in the question stem. There are many morphological abnormalities or dysmorphisms in Edwards syndrome, but let's first discuss those which are specific or pathognomonic for the Edwards syndrome. Patients with Edwards syndrome commonly have the prominent occiput. In other words, they have a enlarged, protruded occipital bone, which is not present in Patau syndrome or Down syndrome, so it's quite specific for the Edwards syndrome. I'm not saying that it's like 100% specific, but still, when the question stems mention the prominent occiput, they most likely are pointing us towards the diagnosis of the Edwards syndrome. Another very high yield characteristic of the Edwards syndrome is the clenched hands with the overlapping fingers. In this case, we will see that the fists are clenched and the index finger overlaps on the middle finger and the little finger, pinky finger, overlaps on the ring finger. Additionally, patients with Edwards syndrome commonly have limited hip abduction. Okay, now let's move on to the findings, which are not specific for the Edwards syndrome, but still it will complete the picture of this genetic condition. These patients might also have the micrognathia, which literally means small jaw. They might also have the low set ears, which means that the ears, the upper part of the earlobe is below the imaginary line across the eye. They might also have the heart defects and the renal defects. And finally, patients with Edwards syndrome commonly have rocker bottom feet. Rocker bottom feet are usually explained rather than written in the question stem because rocker bottom feet is sort of a buzzword. Once we hear about this, then we think either about Patau syndrome or the Edwards syndrome, right? Mostly. And so they usually say that the patient who presumably has Edwards syndrome has the bilateral convexity of the soles of the feet. And this is just the description of the rocker bottom feet. And just as we mentioned several seconds ago probably, rocker bottom feet are commonly found in Edwards syndrome as well as Patau syndrome. So please don't consider the rocker bottom feet as a specific finding for either Edwards or Pathologic syndrome. It can be present in both. Okay, now let's move on to epiglottitis. Epiglottitis, as the name implies, is the inflammation of the epiglottis. The causative agents of epiglottitis are usually bacterial, and previously the most common causative agent was Haemophilus influenza type B with a capsule containing polyribosyl ribitol phosphate. However, since the Hib vaccine or HIV vaccine is commonly spread and administered between 2 and 18 months of age, the incidence of acute epiglottitis caused specifically by H. influenza type B is decreasing. And in contrast, the incidence of epiglottitis caused by Strep pyogenes and Staph aureus is increasing. Let's talk about the clinical features of epiglottitis. Epiglottitis causes very severe and very acute airway obstruction. You can imagine that the epiglottis, which normally is above the glottis, this is why it's called epiglottis, becomes very swollen, and it can completely obstruct the supraglottic vestibule, interfering with breathing. This causes severe respiratory distress, and the children with epiglottitis usually assume the tripod positioning. In tripod positioning, they sit leaning forward, and their neck is extended because when we extend our neck, we open up the glottis and we open up the airway diameter so that they can breathe easily. Regardless, they still have the stridor. Stridor is the sound elicited by upper airway obstruction or upper airway narrowing. They might also have dysphagia caused by swollen epiglottis, which takes up the space in the laryngopharynx. They might also have dysphonia because epiglottis interferes with emission of the sound waves from the vocal cords. You can imagine that we have the vocal cords at the middle level of the larynx, and they emit the sounds, but then the sounds hit the swollen large epiglottis, which just dampens those sounds. And this is why children with epiglottitis commonly have the voice as if they have the hot potato in their mouth. They might also have the drooling because, once again, swollen epiglottis takes up the space, so secretions accumulate in the oropharynx, in the valvular spaces, and then they come out of the mouth. And additionally, epiglottitis is characterized by very high fever. The reason being that this infection is most likely and most commonly bacterial. Epiglottitis is characterized by a classic X-ray finding of the thumb sign. Thumb sign is when the lateral neck X-ray reveals the enlarged edematous epiglottis, which looks like the human's thumb. However, let me tell you one very high-yield thing. Nobody will lose and waste time doing the X-ray to confirm the diagnosis of epiglottitis once it's suspected. And the reason for this is that epiglottitis is an immediately life-threatening condition. The child might die from the respiratory failure and anoxia due to obstruction of the larynx. Therefore, we need to be very quick and we need to perform the action, and we don't have to waste time on the X-ray. But still, it might be mentioned in the question stem. Speaking of the treatment of epiglottitis, the very first thing that we need to do is to secure the airway. And the way we secure the airway in a child with acute epiglottitis is to intubate them. We perform endotracheal intubation, which secures their airway, and we should do it in the preferably in the OR and not in the emergency department, because intubation might have the different complications in this particular patient, and we might have to do tracheostomy instead of the intubation. So we need to be ready with all of the equipment necessary there. At the same time, we need to administer intravenous antibiotics, for example, amoxicillin or amoxicillin clavulanate, because amoxicillin has activity against H. influenza type B. It also works against the strep. And we need IV antibiotics because IV antibiotics have 100% bioavailability and they work much faster than the oral antibiotics or intramuscular antibiotics. So this was discussion about the epiglottitis, and the last thing that I would like to tell you guys is the thing that actually I already mentioned. This is the prevention of acute epiglottitis. We mentioned that there is the vaccine for H. influenza type B, and this vaccine decreases the incidence of acute epiglottitis caused by H. influenza. Here is a very high-yield thing that I would like to ask you to remember. Even if the child is vaccinated with HIV vaccine, she or he is not completely immune and protected from acute epiglottitis caused by Haemophilus influenza. Guys, can you tell me the reason for this? Let me tell you the answer if you don't have one, but if you have, that's really cool. Acute epiglottitis is usually caused by the typable strains of H. influenza. Typable in this case means encapsulated strains. The Hib vaccine contains polyribosyl ribitol phosphate, which is capsular polysaccharide of only H. influenza type B. But what about, let's say, H. influenza type A, type C? We don't have vaccines against them, therefore we might still get infected, so the child might still get infected with other typable strains of H. influenza and get the acute epiglottitis. This does not prove the inefficiency of the vaccine. So the H. influenza vaccine, just like most of the other vaccines, are very beneficial and they significantly reduce the burden on the patient's health and generally the healthcare system. Okay. Let's now move on to another topic. Let's discuss the evaluation of acute pharyngitis in children. To put it simply, we are now talking about how to differentiate viral sore throat from bacterial sore throat. The first thing that we need to do is to ask ourselves whether the child has viral upper respiratory symptoms. For example, cough is commonly a viral URI symptom. The viral upper respiratory infection can also be accompanied by conjunctivitis, especially infection caused by adenovirus. Let me remind you that upper respiratory infection caused by adenovirus is commonly referred to as pharyngoconjunctivitis. And then oral ulcers are also accompanied by, not accompanied, but oral ulcers are also caused mostly by the viral upper respiratory infections. If we have these signs, then pharyngitis is most likely viral. And for most of the cases, sore throat is caused by the viruses, and therefore we need only supportive care. We might give some oral painkillers and pills which reduce the sore throat, but we don't need any other measures. Needless to say that we do not need to use antibiotics here. But what if the child with a sore throat does not have the signs of viral symptoms? In that case, we need to calculate something called center criteria. Center criteria is not used in all ages. However, we can that wasn't right. So central criteria can be used in many different ages, and we need to calculate the total score in order to evaluate the possibility of group A strep pharyngitis in the patient. And central criteria can can be perceived as a mnemonic. So C stands for cough, and specifically it should be absence of cough. As we mentioned, cough is a viral upper respiratory infection symptom, so if cough is absent, then the patient gets 1 point out of the center criteria. E stands for exudates. If we do the oropharyngeal exam and we see that we have severe whitish exudates on bilateral palatine tonsils, it's more likely to be bacterial rather than viral. However, please don't base your decision about viral versus bacterial pharyngitis only on the presence of exudates or not. And let me tell you why. Because infectious mononucleosis, the disease caused by virus, specifically Epstein-Barr virus, is also accompanied by severe exudates on the palatine tonsils. Now we can understand that just the presence of exudates is not enough to say that the patient's pharyngitis is bacterial in origin. Then N stands for nodes. In other words, strep pharyngitis or strep throat commonly causes cervical lymphadenopathy and especially anterior cervical lymphadenopathy. T stands for temperature, and temperature in bacterial pharyngitis is usually more than 38.3 degrees Celsius. And then we have OR. So in that case, we should talk about the age ranges. Strep throat is much more common in children compared to adults. Therefore, if the patient's age is less than 15, then we give the patient +1 for that age criterion. If the age is anywhere from 15 to 43, then we give 0 points for the age criterion. And finally, if the patient's age is at least 44, then we give -1 points for age criterion. Finally, we calculate the sum of the central criteria, and if the summarized score is 0 to 1, that's almost 100% viral pharyngitis, and we need to pursue the symptomatic therapy with no heroic measures. If it's 2 to 3, then we can do, and we should do, the rapid streptococcal antigen testing. If rapid antigen testing gets positive, comes positive, it means that the patient has streptococcal pharyngitis, and therefore we can start treatment with antibiotics, specifically oral penicillin or amoxicillin. But let's say that the patient's Centaur criteria score is 2 or 3, and we did the rapid streptococcal antigen test and it's negative. Does it rule out the strep throat? Absolutely no. In that case, we should pursue the diagnostic management with throat culture. Throat culture is much more sensitive than the rapid streptococcal antigen test, and if the patient with negative rapid antigen test has a positive throat culture, it still confirms the strep pharyngitis, and we need the oral penicillin or amoxicillin in the treatment of this patient. However, if throat culture is also negative, similar to the rapid strep test, then it means that the patient most likely has the viral pharyngitis and symptomatic therapy will be sufficient. If the central criteria is either 4 or 5, well, some sources say that we can empirically treat the patient with antibiotics because the central criteria score that high is almost 100% bacterial, but the other sources say that we still need to do the rapid streptococcal antigen testing. And this was discussion about evaluation of acute pharyngitis in children. Now let's move on to evaluation of the bilious vomiting in the neonate. When we have a neonate with bilious emesis, the first question that we should ask is the neonate hemodynamically stable or unstable? In other words, if we see hypotension, if we see altered mental status, then the neonate is considered to be unstable, and for the unstable patient, we need to do the emergency laparotomy in order to save time and save the patient. However, when the patient is stable, then we have some time to run more diagnostic tests rather than jumping to action right away. And the first diagnostic test in case of the neonate with bilious vomiting is abdominal X-ray. We might have four possible findings on the abdominal X-ray. First, the free air under the diaphragm. So when we see the X-ray film, we will see the lucencies under the diaphragm domes, and it means that the bowel is perforated somewhere and the air has escaped from the bowels into the peritoneal cavity. This is a true surgical emergency, and the management for the intraperitoneal air and the bowel perforation is emergency laparotomy. Let's say that abdominal X-ray of the neonate shows us the dilated loops of bowel. When we have dilated loops of bowel, then we understand that there is bowel obstruction at some point. But we should think about the genetic causes of bowel obstruction as well. For example, the patient might have meconium ileus, which is the sticky, very hard stools seen in cystic fibrosis, or the patient might have the Hirschsprung's disease. In case of Hirschsprung's disease, let me tell you that this is the problem of the neural crest cell migration all the way to the sigmoid colon and the rectum. And then, since there is no myenteric plexus in the sigmoid colon and the rectum, then postganglionic inhibitory neurons, which normally relax the GI tract, do not exist. This is why the tone in the sigmoid and the rectum will be very high in Hirschsprung's disease, but it will be normal in case of cystic fibrosis and the meconium ileus. And we can differentiate this anal and the rectal tone with rectal manometry. But before we go there, let's get back to the point where we see dilated loops of bowel on the abdominal X-ray. The first thing that we ask is there an increased rectal tone, and is there a delayed passage of the meconium, which is the first stool of the baby? If the answer is yes to either of these questions, then we do the contrast enema to visualize the colon. If we have the microcolon, this is most likely to be meconium ileus. Let's talk about the mechanism of why we have the microcolon in meconium ileus. When the patient with cystic fibrosis develops meconium ileus, they have this very, very hard and very sticky stools, and this massive stool usually gets lodged at the level of ileocecal valve, because this is the narrowest point in the GI tract. If ileocecal valve is closed and obstructed by meconium, by this sticky meconium, it means that the secretions and the fecal masses no longer go into the colon. So the colon no longer gets distended, and it becomes almost like collapsed. This is why we say that meconium ileus is associated with microcolon on the contrast enema. In contrast, if we see rectosigmoid transition zone, this is suggestive of Hirschsprung's disease. In rectosigmoid transition zone, what we mean here is that there is a rapid, very abrupt transition zone on the X-ray between the ganglionic segment of the colon, meaning the segment that's normally innervated by the myenteric plexus, and the aganglionic segment, the one that is not innervated, which is usually the rectum, and it might also involve the distal part of the sigmoid. So we will have a very, very narrow and collapsed rectum and the part of the sigmoid colon, and then we will have dilated part of the descending colon, which is immediately above the transition point. And it's dilated because the distal GI tract is very narrow. It is collapsed, and those secretions and the fecal masses accumulate in that place. Okay. Now, what happens if we find out that abdominal X-ray is normal? If abdominal X-ray is normal, we should perform upper GI series or barium swallow. And the reason we are doing this is to screen for malrotation. Malrotation can commonly cause bilious emesis, especially if it's complicated by the midgut volvulus. Let me remind you guys that midgut malrotation is caused by incomplete or insufficient rotation of the midgut around the superior mesenteric artery in between the 6 and 10 weeks of gestation. Normally, the midgut should rotate by 270 degrees counterclockwise, but if it does not complete this full rotation, this is when the neonate might be born with malrotation. How we will find out on the upper GI series that the infant has malrotation? Well, if we see the ligament of Treitz on the right side, this is suggestive of malrotation. What is the reason for this? Well, ligament of Treitz is normally found on the left side. Guys, can you please remind me what is the function of ligament of Treitz? Are you saying that ligament of Treitz holds the duodenojejunal junction in place? If you are totally correct. And duodenojejunal junction is on the left side of the abdomen. So once again, if the ligament of Treitz is on the right side, that suggests malrotation. And the final sign that we might see in a neonate with bilious emesis is double bubble sign. And I am almost sure that double bubble sign, these words ring the bell in your heads. So what disease is associated with double bubble sign? Do you remember it, guys? Yes, it's duodenotresia, which is very commonly associated with Down syndrome. And this was discussion about the management, or to be more specific, evaluation of the bilious emesis in the neonate. Now let's talk about the evaluation of the neonatal hydration. First off, we should talk about the signs by which we can at least suspect the neonatal dehydration. And the first sign is very obvious. This is decreased amount of the wet diapers. Normally, during the first week of life, the number of wet diapers per day is approximately equal to the day of life. To help you understand it even better, let me give you an example. If we have a neonate who is 5 days old, her or his number of wet diapers per day should be approximately 5. And this rule applies only for the first week of life. If we have significantly decreased amounts of the wet diapers, then we can suspect that the neonate is dehydrated. For example, let's say that 5 days old neonate has only 2 wet diapers per day. This is very abnormal. At the same time, if the neonate doesn't have the tears, absence of the tears is another sign of dehydration. Or let's say sunken fontanelle means that there is dehydration and there is insufficient filtration of the plasma and insufficient CSF production in the choroid plexus. This is why intracranial pressure is decreased and the fontanelle is sunken. Mucous membranes might also be dry, and this is the sign of dehydration not only in the neonates but in almost any ages. Skin turgor might be also decreased, and capillary refill time might be decreased. Capillary refill time is directly proportional to the volume of blood and also patency of the arterioles and the capillaries. The normal capillary refill time is less than 2 seconds. And the way we measure it is that we just pinch the patient's fingers, and when we pinch the finger, we compress the capillaries, right? So it means that the pinched part should become white because there is less blood flow while we pinch the finger. And then once we let it go, then it should become red in less than 2 seconds. This is what we mean capillary refill time of less than 2 seconds. Okay, these were the signs of dehydration. But then the question is, if we diagnose neonatal dehydration, how do we treat him or her? It depends on the amount of weight loss within the first 5 days. Normally, the neonates lose approximately 7%, up to 7% of birth weight in the first 5 days. And if the neonate has lost maximum of 7%, that's actually normal. Therefore, we should encourage the mother to continue exclusive breastfeeding, meaning we don't need to add the formula to this baby's diet, and we should definitely follow up this baby at approximately 10 to 14 days, because this is actually the time when the birth weight is regained, and we should make sure that the baby has actually regained the weight, because if not, then there might be truly the neonatal dehydration, and we might need to change the management of this neonate. Let's now talk about the situation when the infant, specifically neonate, has lost at least 7% of her or his birth weight in the first 5 days or so. This is clearly abnormal, and we should assess for the different reasons of dehydration. There might be the oromotor dysfunction. Let's say that the infant has cleft lip or cleft palate. In that case, the latching or the attachment to the breast might be abnormal and might be insufficient, and this might be the reason why neonate is not getting enough breast milk. At the same time, if the weight loss is excessive in the neonates, we should weigh them daily to document their weight, and we should also consider the formula supplementation together with breast milk if breast milk is not enough for that baby. And this was discussion about the evaluation of neonatal hydration. Now we'll talk about the febrile seizures. Febrile seizure, as the name implies, is the seizure caused by an extremely high temperature. And therefore, the first and the most important risk factor for the febrile seizure is fever. It might be surprising to tell this, but febrile seizure is typically associated with the viral infections rather than bacterial infections. And this is probably a good place for me to say one very important thing. The degree of fever or pyrexia is not an absolutely reliable differentiating factor between viral and bacterial infection. Yes, we tend to think that bacterial infections usually cause higher fever than the viral infection, but that's not always true. And let me give you an example to make it clearer for you. Let's remind ourselves of the virus that causes roseola infantum or exanthum subitum. Do you remember the virus for this? Actually, viruses for this condition. That's really cool. This is human herpes virus 6 and human herpes virus 7, although the 6th one is more common than the 7th. Roseola infantum is characterized by very high fever, so high that it might actually cause a febrile seizure, followed by the resolution of the fever and the exanthem or the rash all over the body. So once again, high fever does not always mean bacterial infection. Risk factor for febrile seizures are also the family history of seizures. However, febrile seizure is not an epilepsy. Epilepsy is unprovoked recurrent seizures, but when we say febrile seizure, it automatically means that the seizure is considered to be caused by high fever. Also, febrile seizure might happen due to recent vaccination, if vaccination causes fever, but let me tell you that having a febrile seizure after vaccination is not a contraindication to the vaccination and to the next doses of the same vaccine. The reason is that febrile seizure is usually not life-threatening condition. It is commonly treated very successfully, and therefore the risks of not getting a certain vaccination is usually higher, is usually, yeah, so the risks are higher than basically benefit of not getting the vaccination. So once again, febrile seizure after recent vaccination is not a contraindication to that vaccination. Usually, febrile seizure happens from 6 months to 5 years, and the other diagnostic criteria make sure that we rule out the other causes of seizure. For example, the patient, in order to be diagnosed with febrile seizure, must not have the previous afebrile seizures, because if the patient had seizure without the fever, it means that they might have some kind of either anatomical abnormality in their CNS, or they might have the undiagnosed epilepsy. So and then the patient with epilepsy can definitely get the fever, right? And so epileptic attack can coincide with the fever, but this will not be considered to be a febrile seizure. Another very important diagnostic criteria is that the patient with seizure, in order to be diagnosed with febrile seizure, must not have the signs of CNS infection, meaning the signs of meningitis, encephalitis, or meningoencephalitis. Because in that case, if the patient is presumed or diagnosed to have any of these three CNS infections and has the seizure, we cannot say that the patient has febrile seizure. In that case, seizure is most likely caused by the involvement of those structures, either meninges or the brain parenchyma or both of them. And finally, there must not be any acute metabolic cause of the seizure, for example, hypoglycemia. If the patient has fever and concomitant severe hypoglycemia and the patient develops seizure, the seizure might be due to hypoglycemia rather than due to fever. And in this situation, we cannot say that the patient had febrile seizure. Finally, how do we manage the febrile seizure? Well, first of all, febrile seizure is managed with antipyretics to decrease the temperature, and the abortive therapy for the seizure is used only if the seizure transforms into the status epilepticus. Guys, can you please remind me the definition of status epilepticus? This is when the patient has either continuous seizure for at least 5 minutes or has episodic seizures without complete regain of the consciousness. And finally, after we abort the seizure and after we give the antipyretic medications, we should reassure the parents. Why can we reassure the parents? Because prognosis of the child with febrile seizure is relatively good. Usually, febrile seizures have no long-term sequelae, for example, intellectual disability or things like this. At the same time, the risk of subsequent febrile seizure is increased, but the risk of epilepsy is only slightly increased, maybe by 1%, but not more. Therefore, the parents commonly have the question like, is my child going to develop epilepsy, or is this the epilepsy? And we should be able to answer that febrile seizure is not an epilepsy, and the risk for developing epilepsy in the future is very minuscule. It's like almost 1%, not more than 1%. And this was discussion about the febrile seizure. Let's briefly talk about the fetal alcohol syndrome as well. Fetal alcohol syndrome is, not surprisingly, caused by in utero exposure of the fetus to the alcohol consumed by mother. Fetal alcohol syndrome is a group or spectrum of disorders. So we have fetal alcohol spectrum disorders, one of which is fetal alcohol syndrome. And in order to diagnose fetal alcohol syndrome, we should have 3 criteria met by the patient. The first criteria consists of 3 facial abnormalities, which I guess all of us know. These are the facial abnormalities that are very recognizable in the patient. And we should have presence of all 3 facial abnormalities. This is smooth philtrum, or the smooth groove between the nasal cartilage and the upper lip, thin vermilion border, meaning thin upper lip, and the small palpebral fissures. We say that we should have all 3 facial abnormalities because if the patient has isolated thin upper lip, this does not mean that the patient has fetal alcohol syndrome. The patient might have simply just thin upper lip without any disruptions in the growth or in the CNS development, right? And that brings me to the discussion of the two other criteria for fetal alcohol syndrome. The second one is growth retardation, which should be present in order to diagnose the patient with fetal alcohol syndrome. And the third one is CNS abnormalities. And the CNS abnormalities may come in different flavors. It might be intellectual disability. Patient with fetal alcohol syndrome might actually have the ADHD, which is very common in this syndrome. And finally, it might also be complicated by seizure. So, to summarize, in order to diagnose a child with fetal alcohol syndrome, we should have all these three criteria met by the patient. And when we talk about the facial abnormalities, the patient should meet all three facial abnormalities as the criteria, which is smooth philtrum, thin upper lip, and small palpebral fissures. And the last topic of our today's episode is fetal Hydantoin syndrome. Hydantoin is the chemical substance which is the precursor to the phenytoin, anti-epileptic drug. And fetal Hydantoin syndrome is most commonly caused by in utero exposure of the fetus to phenytoin. This is when the mother has seizure disorder and she takes the phenytoin during the pregnancy. This is especially during the first trimester when the fetus is especially susceptible to the teratogens, and this is when the fetal Hydantoin syndrome can occur. Fetal Hydantoin syndrome can also develop secondary to carbamazepine use during the pregnancy, but it's much of a less common cause of fetal Hydantoin syndrome than the phenytoin. And fetal Hydantoin syndrome has four main characteristics. First, it is characterized by microcephaly, but I think you will agree with me if I say that we cannot diagnose fetal Hydantoin syndrome with just microcephaly. Microcephaly might be a benign finding with familial microcephaly. It might also be the sign of torch infection. So just microcephaly is certainly not enough to diagnose fetal Hydantoin syndrome. These patients also commonly have the cleft lip or the palate, and they have the cardiac defects as well. And the fourth and the final finding, which is much more specific than the other three that we already discussed, is hypoplasia of the nails and the phalanges. If you see the picture of the patient in the question stem, or if they describe the fact that the neonate's nails and the distal phalanges are hypoplastic or malformed, then they are most likely talking about the fetal Hydantoin syndrome. And then the question usually asks, in utero exposure of which of the following substances might be the cause of the fetal abnormalities that we see. Okay, we have come to an end of our today's episode, and let's summarize briefly everything that we've discussed today. We have discussed multiple different topics across the pediatrics today, and the main take-home message for practically all of these topics is to know their current diagnostic algorithm, evaluation, if any, and also their treatment. You can leave the voice message on this episode to let us know how we can improve our podcast for you. So thank you for your kind attention, zoosemmeliers, and see you on the next episode.